All right, so I'll be talking next as a brief background. So, after medical school and residency, I went into practice in rural South Carolina. Did very broad-based surgery, did everything, head to toe, trauma, vascular, and then went back and did a fellowship focused on cancer at Moffitt Cancer Center, actually. And from there, I went into practice, actually helped start the Lakeland Cancer Center. We didn't have a cancer center in Lakeland, so Lakeland Regional Cancer Center. And then I was recruited to come up to Mayo Clinic in Rochester. So I went up to Mayo Clinic in Rochester. Where there I focused purely on breast cancer and skin cancers, melanoma, Merkel cell, et cetera. So I was up there for 13 winters. And then came back to Florida. My wife's talking to me again, so everything's good. So came back down 4 years ago and have been at Mayo Clinic, Florida now for 4 years, but had been in the Mayo system for the past 17 years. And again, my practice is breast cancer and melanoma. So I'm going to talk about the surgical management of melanoma. So one leopard says to the other, "It's nothing. My doctor removed some spots he was concerned about." So there's not a whole lot of good animal cartoon melanoma jokes, but I got one to start with and one in the end. So in trying to convince younger people to stay out of the sun, it's really an uphill battle, right? We all probably remember doing the tinfoil thing and up on the roof and baby oil. And, if you tell the teenager or the early 20 that they're not going to live to be 50, they don't really care because they don't want to live to be 50. They think that'd be a terrible thing. So the strategy of you're going to get cancer in the future really actually isn't that effective. So you have to use their vanity, and you have to tell them they're going to get wrinkles. And they're not going to be cute wrinkles like these are, but they're going to get very, very wrinkly skin, not only their face, their hands, their neck. And so sometimes that can be more effective. So I met Heather when she was 21 years old. I was on call for the emergency room, and she came in with abdominal pain, and she had appendicitis. Heather was concerned about her abdominal pain. I was more concerned about that spot in her neck. So went to surgery, did a laparoscopic appendectomy, uneventful. She went home the next day. While she was in surgery, got approval from her to do a biopsy of that lesion. I saw her back. That was obviously a melanoma. It was a thick melanoma, pretty aggressive. Did a wide excision, did a sentinel node biopsy, which is positive, had to go back and clean out the lymph nodes from her neck. This is 2005. So we didn't have any effective therapy for node-positive melanoma. And at that time, we had a trial, a research study with interferon. Interferon is a drug that we used for melanoma that's quite toxic, and it doesn't really work very well. Makes people sick like they have the flu essentially for a year. And maybe out of 100 people, it cures one or two more. So that was the best we had. And at that time, this was even on a research study. It wasn't standard. So Heather kind of was a bit estranged from her family. She moved down to Florida from Indiana, and she had a boyfriend. When I saw her back 2 years later, she had just had a baby, and she was postpartum, and she looked terrible. She was cachectic, had lost a lot of weight, was clearly very ill. And we did evaluation for her, and she had stage 4 disease at that time. And she just wanted to get back home to her family, actually. And so we ended up evaluating her, and she had a lot of fluid on her lungs. Pleural effusions are called. So she wasn't safe to travel. So we admitted her to the hospital. We got her stabilized. Again, we had no effective therapy. She was really, really advanced. And so she went back to her family in Indiana for 4 months and under hospice care and died. So terrible, tragic story. The reality of that story is if she presented today, her outcome would likely be very, very different. So in my short career, what she had experienced would be totally, totally different today. And that's thanks to all the research, obviously, and all the advances we've made. So when we talk about staging of, so when we talk about, so getting a little choked up talking about Heather. So when we talk about a staging of melanoma, we talk about the T and M staging. That's why we stage all solid tumors. So T is the tumor size, but for melanoma, it's not how big it is. That's not relevant. It's how deep it invades the skin. That's how we measure the tumor size. N stands for nodal status, And this is a universal international staging system, TNM, we all use. Sometimes people will tell us they're T stage and they'll think that's their stage. So each of these, T has a 1 through 4, N has a number, but the final stage is a stage that's 1, 2, 3, 4. So each of these categories make up that final stage. And then metastases if they're spread to other organs. So this was already shown essentially, but we stage melanoma. It's how deep it invades the skin. That can only be determined by a microscope. You can't see that with your eye. So we're talking about depth of invasion, and some of this is review. So I think of it as three broad categories. A thin melanoma, which fortunately the majority of melanomas we now see are thin, is less than a millimeter. A millimeter is the thickness of a dime. So again, this is a microscopic finding. You can't differentiate these with your eyes. A thick melanoma is greater than 4 millimeters under the microscope, and in the middle, we call intermediate, is between 1 and 4. Now, this is measured with a microscope, and something I want you to hear, because there's a lot of confusion. Patients will see their Clark level, which is a different way to measure than it'll be in your path report. They'll have the Breslow thickness, the Clark level, and people will be very concerned because they see Clark level 4. They think that's their stage. Clark level is not your stage. So we stage here, as Dr. Tolomat went through, stage 0, non-invasive pre-melanoma is melanoma in situ. That's a stage 0. Stage 1 or 2 means it's confined to the skin. Stage 3 means it's spread to the lymph nodes. And stage 4 means it's spread to other organs. So melanoma in situ. Melanoma in situ is a precancer. It's not invasive. It's stage 0. Melanoma in situ does not kill anybody. The only reason we treat melanoma is to prevent it from becoming an invasive melanoma, stage 1, 2. Now, the problem with melanoma in situ, especially on the face, is sometimes it can be fairly extensive. It can be pretty sneaky and pretty insidious, and kind of differentiating where that starts or ends can be challenging. So sometimes you need big excisions to excise melanoma in situ. But again, melanoma in situ is not a lethal disease. We're not curing cancer by removing melanoma in situ. We're preventing a cancer. In terms of excision, conservative excisions around the lesion with not a super wide margin, we typically do for some dysplastic nevi and melanoma in situ. These are done in the office under local anesthesia. And for thin melanomas also, almost all thin melanomas are treated similarly. The margins now are getting wider because it's invasive. About a 1 centimeter margin around that spot is drawn out there. And that is done typically in the office under local anesthesia. Some thin melanomas, more aggressive thin, we have to check lymph nodes, but the majority of thin do not need to see someone like me and do not need lymph node surgery. Excellent survival for thin melanomas. And now we get into the intermediate and thick melanomas. So this typically requires going to the operating room, typically involves us checking the lymph nodes if there's no evidence of lymph node disease, called a sentinel lymph node biopsy, which we'll talk about here. And with this wider margin, based on how deep it is, sometimes now we're going 2 centimeters. So we have specific guidelines based on how deep the melanoma invades, how wide we go. And when you're going 2 centimeters now, getting closure, things pulled together can be challenging. And not infrequently, we're looking at skin grafts and flaps. And the wound complications and stuff can certainly become more involved. So this is an example. That's a 1 centimeter spot there, we'll say, on the screen. And so if I have to do a 2 centimeter wide local excision, that's how wide I'm going. So that little tiny spot now, I'm taking out 5 centimeters. But I really can't close a circle very well. So I have to convert that to an ellipse, a straight line. And we have a 3-to-1 rule generally in surgery to close a circle. However big that circle is, you have to go 3 times as long to get that closed. So we started with that little dot there. That was 1 centimeter. And now we have a 15 centimeter incision, which is 15 centimeters, which is 6 inches. So all that skin comes out around that 1 centimeter spot. So started with that, and that's the skin we're taking. And so here's a real patient example. So there's a melanoma. You can see a little biopsy in the middle. And there's the patient in surgery with me. So that's going to be about 2 by 6 inches now, 5 by 15 centimeters. That X on the groin there, that's where the sentinel node is. So I'm going to remove that sentinel lymph node along with the wide incision. You can see I was probably teaching a medical student or resident over here. I have my little notes here. So there is an international trial going on now, which we're participating in. This was started in the UK. I was one of the reviewers for the protocol. I was sent by the government of the UK to review the protocol. Thought they wanted my opinion if I thought this was good research, if this was valid, if this was worth them investing UK dollars in. And it's also run out of Australia, which you probably know has the highest incidence in the world of melanoma, and Canada, US. So this is looking at patients who currently our best practice, our guidelines are to take 2 centimeter margins. And in this trial, patients who are agreeable, we're randomizing them, where half will get a 1 centimeter margin, half will get a 2 centimeter margin. So the goal of that trial is to show that we hope to show that the recurrence rate, the cure rate, the survival is the same if we can do a more narrow margin, but significantly lower costs, lower complications, lower morbidity, not needing to do flaps and skin grafts and all those kind of things. So this has been a lot of my practice, is trying to have the same, at least same cure survival with less and less morbid, better quality of life procedures. Because obviously patients, as you all know, who have these diseases, whether it be melanoma, breast cancer, have to live with the consequences of the interventions we do for the rest of their life. And I'll just make note here, there's been a lot of talk lately of that the government shouldn't be funding studies, industry should. And I agree, industry has huge partnerships, but no industry in the world is going to fund this study. What industry cares if I go 2 centimeters or 1 centimeter? No one's going to pay for that. So if the governments are not funding this, and I can tell you Australia is a leader, that almost all the melanoma trials that we're doing nationally are coming out of Australia. Their government is very much funding and pushing these and pushing us and challenging us to try to keep up with them. So lymph nodes. So lymph nodes should be where your immune system fights the melanoma, but paradoxically, it's the first place the cancer often spreads. And we're doing a lot of research in that space. In terms of lymph nodes, the original, back before sentinel node biopsy was developed in 1995 as a technique, we had a conundrum when we saw patients. So you got a melanoma, maybe it spread to the lymph nodes. We don't feel any lymph nodes. So our option was to just watch those lymph nodes. And in 20% of patients, if we watched them, then a year or two later, they would show up with a big palpable node. Option two is just clean them all out, remove them all. But then 80% of the time we say, great, 30 negative lymph nodes, and now the patient has arm lymphedema. So that was our standard up till 1995, till sentinel node biopsy was developed. And this video is going to do a better job than me. So I'm just going to play this short 1-minute video. This is on our Mayo website. You can see right here of what sentinel node biopsy is.
The thicker a melanoma becomes, the greater the risk of it spreading into the lymphatic system and lymph nodes. Unless the lymph nodes are enlarged and visible during the physical exam or on imaging tests, the only way to accurately determine whether cancer has spread to the lymph nodes is to remove the lymph nodes. The path of the initial lymph drainage and extent of tumor spread can be determined by locating the sentinel lymph node, the first node that filters lymph fluid draining from the melanoma. In some melanomas, tumor cells can travel in more than one direction within the lymph system. Sometimes there is more than one sentinel lymph node. To determine the location of the sentinel node or nodes before surgery, a radioactive material is injected into the skin around the site of the original melanoma. The radioactive substance travels through the lymph channels and collects in the sentinel node. A body scan done several minutes after the injection identifies the sentinel node's position. To help view the sentinel node during the operation, the surgeon injects a blue dye into the skin around the melanoma. Like the radioactive material, the dye also drains by lymphatic channels to the sentinel node. A small incision is made near the sentinel lymph node. The presence of the blue dye and an instrument that detects radiation allow the surgeon to identify the sentinel node. The node is removed and sent to a pathologist who slices it into multiple pieces. Each slice is examined under a microscope for melanoma cells. Special stains also are used to help visualize even a tiny number of cancer cells. If melanoma has spread to the sentinel lymph node, the other nodes in this area are surgically removed to be certain they do not contain additional melanoma cells. The thicker a melanoma becomes, the greater the risk of it spreading into the...
Testing my tech skills. Okay. So sentinel node biopsy. So we don't do it for atypical nevi. We don't do it for melanoma in situ. We don't do it for most thin melanomas, but we do almost standard do it for patients who have melanomas greater than 1 millimeter Breslow depth. That's what a sentinel lymph node looks like when I'm operating. In that that's an axilla there. There's probably 40 lymph nodes in there. And it's really amazing. You inject this blue dye or this radioactive colloid, it travels, it gets trapped in the first 1 or 2 nodes and gets stuck there. And you can see, I can see that there. And then I have a gamma probe that counts radiation, kind of beep, 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 beep. And that node will be hot where all the neighboring ones will be negative. So we can very precisely identify the node draining from that part of the body. Important for people to understand that when we do the X-ray that they described, inject the radioactive material and see that sentinel node, that is not a cancer scan. That is purely an anatomic roadmap. That's taking us to the first node draining from the body, just like your GPS. So if I injected that radioactive colloid right here today, it would drain to a lymph node. That's just an anatomic roadmap of what lymph node is draining that part of my skin. If I injected it here, it would probably go to a different lymph node. So these metastases can be sneaky. So I don't know if you see that GI there, but he's there. And this is the way melanoma can be on the slides too. And that's why we cut them up into lots of little pieces, because the focus of melanoma can be tiny. You certainly can have a negative PET scan, negative ultrasound, and have a little bit of melanoma in that lymph node. No scan, no imaging is going to be as accurate as a microscope. So that lymph node looks pretty normal, and then you put this special dye on there, and those are melanoma cells that easily could be hidden. So historically, and even in that video that was created in 2006, we talked about if you had a positive sentinel lymph node, then we took all the lymph nodes out. And that's true. In 1995, when sentinel node biopsy was developed, the goal was for patients who had negative sentinel lymph nodes to not get a lymph node dissection. The goal was never, if you had a positive sentinel node, not to remove all the rest of them. So that's what we did for 15 years. But there was a very large study that changed our current practice a few years ago. And what we did, this is again an international trial where patients who had a positive sentinel lymph node agreed to be randomized. Half of the patients had a full lymph node dissection, which was the standard at the time, and half stopped at that point, did not have any additional surgery. And this was published in probably the most premier journal in medicine, New England Journal of Medicine. And what we showed, there was no survival difference in patients who had a positive sentinel lymph node, whether we did a lymph node dissection or not. So from that 2006 video, we don't check the lymph nodes when we do sentinel biopsy in the OR anymore. And for the most part, we rarely do a full lymph node dissection for a patient who has a positive sentinel node. And not to be a broken record, but my field obviously is surgical oncology. So there's not a whole lot of, or any industry, private people who are going to pay for a study like this. That's affecting now our entire practice around the world. And industry absolutely should buck up, should step up, should pay for trials that is going to affect their bottom line, right? Is going to advance their drugs and therapeutics. But no one's going to pay for these studies except the US government or Australia or UK. So we now changed our practice because of this study. So complete lymph node dissections, the main body parts, the areas that we do these, there are others, but primarily in the neck, the armpit, and the groin. So I'm going to show a slide. It's a visual from surgery. So if you're kind of grossed out, you can just close your eyes for a second. But this is what I do every day. So that's a lymph node dissection. That's pretty aggressive lymph node dissection in the groin. And so you're looking at some of the muscles of the leg there. You're looking at the artery, the vein, the nerve that's supplying that leg. And this is a standard groin dissection. And unfortunately, this has complications because groins are dirty, dark places, lots of bacteria, lots of lymphatics, and they leak, and they're not uncommon to have a situation like this. So we helped develop and pioneered this minimally invasive lymph node dissection. Again, a less aggressive surgery, doing the same operation, but now like laparoscopic gallbladder surgery, doing it with cameras. And this has been very successful. So now when I do lymph node dissections for appropriate patients, some patients, we can't do the minimally invasive approach. But instead of that big incision that you saw, they end up with something like this. So this scar and this scar was their sentinel node biopsy site. And you can see that's longer than me doing the full lymph node dissection. So we helped pioneer this. We had a number of centers come out to Mayo, from Memorial Sloan Kettering, Duke, Ohio State, John Wayne Cancer Institute. We taught them this technique, and then they went in a cadaver lab. They went home and did this technique. They sent us all their data, and now we've established that this is just as effective as doing the standard open approach. So again, a study that industry is not going to pay for. This is a patient, that's a PET scan. So that's her armpit, and that shows a big, really avid, FDG, active, pretty large lymph node. So not too long ago, the standard would be not too long ago, like a year ago, back in the dark ages, 12 months ago, would be to take that patient and clean out all those lymph nodes. But now, and this patient was on a trial, we gave her immunotherapy before surgery. When I went to operate, there was no cancer. Immunotherapy took care of it. And there were 2 large studies, again, to be like a broken record. These were multiple large institution, multinational studies. And both of these showed that if we give you in patients who have known lymph node disease, if we give the immunotherapy before surgery, their survival is actually better. Not only do we less aggressive surgery, but we actually cure more people because we have the lymph node where the immune cells are and the cancer together. So when you turn on the immune system can recognize those cancer cells as opposed to taking the cancer cells out first. So this has dramatically changed our practice like overnight. Once this was presented and published, everybody just changed to doing this. It was disseminated almost immediately. Historically, when research trials are presented or published, it takes on average 3-5 years or more for them to be disseminated broadly. But that's changing the way we communicate. And last year, 2024. Yeah. So my summary, most melanomas we diagnose are early stage and curable. Surgery remains the mainstay of treatment. The extent of surgery is primarily driven by the Breslow depth and the stage, meaning are lymph nodes involved or not involved. We have many new approaches, and they're becoming more and more individualized and less aggressive, which is a win-win, while we increase cures. So back to my non-funny melanoma jokes. So maybe next time you'll try a little sunscreen, the pig telling the bacon. Yeah. All right. I'll be happy to answer any questions.
So in reference to that study, it's for you specifically as a doctor. So typically what we see is that a study gets published, people read it, and you guys start doing whatever you're going to do as a reaction to it. Is there, with social media out there, do you have your own personal network of people that you're dealing with on a monthly call, a monthly Zoom, to saying, hey, what are you seeing? What are you hearing? What are you reading? And is there something new out there that maybe gets this stuff pushed out quicker?
Yeah, so it depends on how engaged the physician community is, right? So if you're like me and this is where you live, then absolutely. I just got back from the Society of Surgical Oncology meeting in March. I just got back from the American Society of Breast Surgeon in May. I was presenting at that meeting. I was networking with my colleagues. Last night, I was on a call with SWOG, the Southwestern Oncology Group, presenting a study concept that I'm hoping SWOG, but is really NIH, okay? Pitching an idea to SWOG. If SWOG endorses it, they pitch it to the NIH. If the NIH agrees to fund it, then we fund it, which is doing something similar for stage 2 melanoma, advanced stage 2, not an early stage 2, advanced stage 2, where my theory is right now, the practice is if you have an advanced stage 2 melanoma and you have it excised, then you're available to get a year of immunotherapy. And a year of immunotherapy has been shown to improve outcomes. However, it's a year of immunotherapy, very expensive. Only about 20% of providers, and the uptake rate's only about 20% right now for people who are eligible. So the trial design is 2 cycles of immunotherapy, then surgery, and stop, versus the standard of care, be a randomized trial versus a standard. So that was something I was pitching yesterday to the SWOG group. Again, SWOG has to endorse it. If they endorse it, it goes to NIH. If NIH will fund it, then that would be the trial. And that's the only way to change practice, is to show that this is as good as this. The current best practice, we think this is better, and yes, indeed, this is better. Now, if you're a general surgeon, which I was, and it's hard work, but I was doing vascular one day, I was doing breast cancer the next day, I was doing a gallbladder the next day. So am I able to keep up and know what's going on in this space? No, it's impossible to, right? You can't do that with every single disease. So it depends on how engaged the individual specialist is, yeah.
I went through immunotherapy here for a year. And during that time, they were doing PET scans every 3 months to dictate. When they completed that, they went to CAT scans, but the CAT scan, I think, only comes up to about here. And I had 3 melanomas in this area. What is the best test to check to make sure that I don't getting above that area.
Yeah, we can ask Dr. Dronka her opinion too. So I think the PET scan is the single best test. Now, the PET scan does not look at the brain. PET scan is based on glucose metabolism, and your brain can only use glucose. It can't use protein or fat for energy. So when you do a PET scan, your brain, it should, lights up like a Christmas tree. And so you can't really scan the brain very well with a PET scan, but everything else you can look at pretty well. Now, you can't, insurance gets into this, and how many times can you do a PET scan and how much is too much, and can you only get one a year? So I would say standard is typically for looking for systemic disease, not just looking at lymph nodes, is a CAT scan, chest, abdomen, pelvis, MRI brain, or PET scan plus or minus MRI brain. Now, for certain regional basins, an ultrasound can be just effective. So if we do a sentinel node biopsy and it's positive, but we're not going to do a full lymph node dissection, sometimes we'll ultrasound that regional basin to look for an early recurrence of melanoma. So it depends on what you're looking for. If you're looking for distant spread, brain, bone, liver, lungs, then PET scan with MRI or CT scan, chest, abdomen, pelvis with MRI are equivalent. If you're looking for regional, you're right, you would need to do a CT of the neck, which is not standard, or you'd need to be ultrasounding that area.
It did metastasize, and they took my parotid gland out.
Yeah.
And, but I don't think that the CAT scan I'm getting now goes
No,
all the way up to my ear.
correct. That's correct. Yes. Good, Mike?
She has.
Oh,
What is the lag time between, let's say, publication and insurance companies covering? Because you have a lot of statistical information to say this over here is the way we need to be doing this.
yeah.
There's a long time before you can get an insurance company.
Yeah, that's a great question. I think I'm going to hold that one for Dr. Dronka, and remind me and ask that one for her, because I don't think I'll be able to give you as good of an answer as she will be able to. She lives in that space every day.